the first long talk I ever heard on CHARS syndrome. So really, I'm looking forward for questions from the audience later on. We move now to some case reports. I will have one package of small case reports from Professor Khurana from Delhi. Ashok Khurana is a good friend from Delhi, and he's very often on the extempore group in both in gynecology and obstetrics. He's a professor of radiology and consultant in reproductive ultrasound. He's the head of the radiology and ultrasound lab in New Delhi and organizing many on-site and online meetings. So please, Ashok, show us the few cases you put together on the cerebellum.
A very good evening, and my thanks to Professor Ravi Shawi and the Eastern European Professional Meeting for including me in this winter meeting on ultrasound and obstetrics and gynecology. I bring you greetings from the Society of Fetal Medicine in India, which works together with the Ukraine group to bring about some of this education. I'm going to talk about the syndromic aspect of the transverse cerebellar diameter beyond dating and beyond fetal growth restriction. And we know in this situation that the transverse cerebellar diameter is the maximum diameter of the cerebellum on an axial scan in a standard plane, which we call the transcerebellar plane. It's frequently used as a parameter in addition to the BPD, the head circumference, the abdominal circumference, and femur length for dating a pregnancy and for assessing growth. It's affected only very late in growth disorders and serves as a very useful dating parameter in fetal growth restriction, and its measurement in millimeters is conveniently equal to the gestational age between 17 to 22 weeks of gestation. More importantly, we do understand that it is an integral part of the checklist for assessment of the fetal brain at the mid-trimester anomaly scan. Now, it is actually a surrogate marker for cerebellar hyperplasia, which refers to a reduced cerebellar volume due to the maldevelopment of one or both hemispheres. The vermis is small, but completely normally shaped, and the condition should be suspected when cerebellar biometry, which is the transverse diameter, is below 2 standard deviations for gestational age. And it includes cerebellar agenesis, unilateral agenesis, and hyperplasia. And the first case I'm showing is that which was otherwise at 20 weeks from the head parameters and the abdominal circumference and bone lengths, but the cerebellar transverse diameter was at the second centile with a size of 17 weeks and 5 days. When we went into a search for this, we realized that it could be a trisomy 9, 13, and 18, a glycosylation disorder, exposure to valproic acid or to cocaine, a genetic cerebellar hyperplasia and pontocerebellar hyperplasia, CMV infection or posterior fossa hemorrhage sequelae. When we looked at the genetics, there seemed to be a baffling array of 369 conditions on just one page and some on other pages of Google as well. And so we decided, well, what do we do next? The first thing was to get the phenotype right. And in that first pregnancy of this patient, we realized that in addition to this, we did find a delayed sulcation of the brain. We did find that we're not able to define the corpus callosum in the midline, that there was bilateral club feet, that there was a partial persistent clenching of one wrist, and in addition to that, there was a flaring of the lower part of the chest. There was no additional evidence of cytomegalovirus infection and no growth restriction, no choroid plexus cyst, and no renal anomaly. She couldn't afford an MRI, but she could afford an amniocentesis where the CMV PCR was negative and a Fisher karyotype were normal. She couldn't afford a microarray. And then we said, okay, let's see you back at 12 weeks in your next pregnancy. There may be something wrong, but let's see what's going on. And she came back, and in this pregnancy too, the findings were similar. delayed sulcation of the brain, a small transverse cerebellar diameter, and of course, a clenched fist, as you see here. The situation here was similar, and no other evidence of a trisomy 18 or a CMV infection or a growth restriction. The autopsy in this second pregnancy confirmed the poor sulcation of the brain and all the other findings of the ultrasound scan. We then went on to say that, look, we have a working diagnosis of a arthrogryposis and a cerebellar hypoplasia. We then went on to think that, okay, let's try and think about from our own smart ideas, and those were no good. We looked up our most favorite reference, which is Barab Nasser's book, and that didn't give us any clues. And then we said, okay, let's look up at the traditional databases. There were so many pages that we really couldn't come up with any answer. And then we said, okay, time to reinvent ourselves and use either an assistive software like Phenotyp or a AI, artificial intelligence-based software like Sonio. And that threw up a wonderful clue. It told us that, yes, this could be a defect in the CoA synthetase enzyme that catalyzes the last steps in the synthesis of coenzyme A from vitamin B5. And sure enough, this yielded a defect in exactly that enzyme, a mutation. We then went on, of course, to do a whole case series. We found 8 cases in 5 families and published them very recently. So that was a good job done, starting with a simple ultrasound phenotype. Our second case was similar, except here, the additional finding was a narrow ascending aorta and an early onset fetal growth restriction. Here, the answer was simple. We knew that the first possibility was a Wolff-Hirschhorn, and that's what the microarray revealed. So the conclusion that I want you to carry home is that AI-based software is evolving rapidly and becoming universally available, and we should be using it. Genetics is becoming increasingly available, cheaper, and user-friendly, and we now have a good guide on what to use when, because this genetics helps us in a diagnosis and appropriate prognostication of this pregnancy as well as future pregnancies. And an ultrasound phenotype is increasingly becoming the focal point for assessing syndromic associations and guiding judicious use of the wide variety of genetic tests. Thank you so much for your attention.
No.
So great. Now we have we still need Oliver Kagan to be also with us. So we have now the speakers who presented the talks here. So we'll see in the chat the questions. One of the questions is how much time are you giving for a comprehensive genetic examination? So the genetic scan, is there a practice to invite other colleagues for a complicated scan? It makes things complicated if you invite more people. So
I don't know. I don't know what is this genetic examination. I know good detailed examination.
Yeah. So
maximum information for genetic service, and every single examination in 15 and 22 and 30 weeks of the pregnancy, not more than 30 minutes.
So let's say the issue is this way. You are scanning and you know it looks like a syndrome and you want now to go through step by step. Julien will watch the semicircular canals, the other one will do 3D like Benoit, some will look at the vessels and so on, and Oliver will count the fingers. So roughly you will be disturbed to do it within our normal schedule. So if you have time, roughly you need 1 hour is okay. Or if you have a second opinion patient, they call, you have one second opinion, you book her time, half an hour.
If I not so,
yeah.
If I not,
yeah, please.
Yes. Okay.
5 minutes, Julian? No.
No. Yeah, 5 minutes, depending on the indication. That's what I wanted to say.
Okay.
There's no, in my opinion, there's no such thing as a comprehensive genetic scan. It really depends on the indication and what the referral sign is. If the patient, say, is referred for a tetralogy of Fallot, then you're scanning for a whole world of syndromes, because we all know that there are hundreds of possible syndromes that are associated with conotruncal cardiac defects. If the patient is referred for a cystic lung lesion or for laparoschisis, then I'm not doing the same kind of scan, right? Because we all know that in laparoschisis, if you can confirm it's a laparoschisis, and if it's not a ruptured omphalocele or something complicated like that, but just as a standard gastroschisis, if it's a standard gastroschisis, then there are really no syndromes to look for, or at least none that I'm aware of. And then I'm really my scan is devoted more to a functional aspect of the laparoschisis. How are the intestines and everything? So the scan will be much shorter. I will be looking at how the baby's growing, how are the intestines, but I'm not looking for syndromes. So I wouldn't be doing a genetic scan. So in my opinion, depending on the referral sign, I would not do the same kind of ultrasound based on the referral sign. But I may be wrong. Huh?
I personally, when they get a phone call for a second opinion, second trimester or so, I will give them 45 minutes. I will anyway, first of all, you will hear 5 minutes what they want, what their expectations, what they know, what Google told them. And then at the end, because this is a life. So because if you, and sometimes I say, I don't like that you Googled before. So, and then we know, as you say, it's a cardiac anomaly. So you will go through and you think on many syndromes and you go through. For example, Oliver, about you. So you have a referral for, let's say, limb anomaly, and you book them roughly
45 minutes. And I start exactly from where you just said. It's the question, what do they know before? Which expectations do they have? What do they want from me? And from there on, I can then carry on with any kind. If they want just if it basically goes in about invasive testing and a whole exome sequencing, that's a completely different story. If as compared if they want a comprehensive anomaly scan and another counseling in terms of the anomaly that's been seen.
In general, in my experience, you need half an hour scan and 15 minutes divided by 5 minutes and 15 discussion explaining and getting to the towels to cry. I will not like to have someone in the room, because if you discuss and the lady says, what are you saying there? And you start to look at the eyes. What is the eyes? I don't see the eyes. And so the ear, what is the ear about? So Franti, what is your experience, František?
Well, it depends. I usually have 20 minutes for one scan.
20?
But 20 minutes, yeah. But if I see something complicated, it depends on scanning conditions and on the findings that I see. And sometimes I reschedule the patient, and I will find, let's say, 60, sometimes even more minutes for one scan. So it depends on the case.
But, well, to be honest, the scanning time itself, that is maybe 20 minutes, if even. If the diagnosis is made already, so you'll go through the baby again and you look for additional anomalies. You'll try to reconfirm the anomalies that's been seen before. But the more problematic aspect is counseling and, well, functional counseling and counseling in terms of the overall setup and the overall prognosis, isn't it?
Yeah, and we had yesterday a very nice presentation by Dr. Abu Hamad on aspect of counseling, how to deal with the situation. And we are experts sitting here giving excellent talks. So in general, you may need, as an experienced scan, 15 minutes, but you need additional 15 minutes to produce the good image, the good face, the 3D, looking to this, that, to make the projection here, to have even a better version to have a video showing nothing and then showing the ear appearing. So this is also part of the scenario. It's not only looking, because we need to document images and so on. So, okay, so there is one question here about what is this? Give me a second. Sir, a calcaneovalgus deformity diagnosis, which gestation can be achieved, and how to make a follow-up and prognosis, and are there other anomalies? It seems as an out of anything question, but why not to answer it? So who would like to answer?
Well, it's, to my best knowledge, I've seen few in the second trimester at about 20 weeks.
Yeah.
And the majority were just associated with nothing. And there was one spina bifida that I've seen in this situation, but I don't know anything else in any other typical genetic syndrome. I don't know.
I've seen once also with microcephaly, it was a sign of syndromic condition, but it is similar to like a rocker bottom foot at the end of the day. It was not. Asma is asking, what is the yield of genome sequencing, or if you offer to all congenital heart abnormalities? Do you always offer genetic testing to all chondrodysplasia punctata? So 2 questions. One is on heart genome sequencing. So to my knowledge, I remember I heard the talk of Mark Kilby recently. He said with the exome sequencing, you run by the heart 35%, and the genome adds 5%. He was citing a Chinese study, 5% additional with the genome to the exome.
Mhm.
And to Franti, are you offering genetic testing to all cases of chondrodysplasia punctata?
Yeah, usually we recommend that, but it depends on our geneticists what they will choose. It's we just do ultrasound, and then the patient is sent to geneticist, and they recommend further examination. So sometimes it doesn't depend on me.
Can you elaborate a few words? Because, you know, we have 2 entities. We have the Binder phase.
Yeah.
And we have the CDP. So, because, you know, when you see the Binder phase, we saw in the talk of Benoit, a flat face of a normal African patient, where the other faces were harlequin faces. And this would have been a very abnormal case if you don't see the parents. And we have seen flat faces with Zellweger. So if you see a Binder face, what is your suggestion for us to do? This could be a question. Next, you scan, you see the flat face.
Yeah, well, we generally recommend genetic testing, because you can some features of chondrodysplasia punctata can be very subtle, and so you can't see them very well. So some features you can see just after delivery. So generally we recommend genetic testing to those babies, because for us in our society, Binder face is very rare. It's not very commonly seen. In other populations, it's more common, but here it is something very striking. It is very striking finding, so we recommend genetic testing to all those cases.
But let's say when you see a flat face, you look at the bones if you have these stipplings. If you don't see them, you don't say CDP, you say Binder face.
Yeah, then my conclusion is just the Binder face.
Okay.
But anyway, I will recommend, because, you know, anyway.
So, Michael, you want to say something?
Yes, I have a question to Julian. What's your experience with the unilateral agenesis of the olfactory sulci?
Well, it has occurred. That's a difficult point. I mean, depending if it's associated with a whole lot of other features of Charge syndrome, then it's easy. You make a diagnosis. It's Charge if you have genesis of semicircular canals, if you have a card defect, if you have so on and so forth. If it's isolated, then there are syndromes that are associated with isolated genesis of olfactory bulbs and fissures in sulci. But these syndromes. The name of the syndrome is
Kallmann
Kallmann de Mortier.
Kallmann
Yeah.
de Mortier. Yeah.
Kallmann de
maybe.
Mortier. And Kallmann de Mortier.
Trisomy 13.
And trisomy, yeah, but let's rule out all the chromosomal defects, because let's make sure that you've had a chromosomal microarray before we discuss all these syndromes. But if you have a normal array CGH, then obviously the only diagnosis that is possible would be Kallmann syndrome. Kallmann syndrome has its own problems, but it's much less severe than a Char syndrome, obviously. And most people with Kallmann syndromes just do well. They have infertility problems. They have endocrine problems going on. They have a specific slightly specific phenotype, but nothing major going on. So that it's a symptom that does exist. And then I just send the patient to a pediatric endocrinologist for counseling, and usually we do well with that. Obviously, get an MRI and also do an MRI.
Sure.
I tell you, my modest experience with the charge, the Surgos olfactorus works very well. There is only one case I had where they were there despite being charged with CHG7.
Yeah.
On the other hand, when I start discovering they are absent 28 weeks, I cannot see the semicircular canals because it's already ossified. So this is why when you see the inner ear, it's not the time where you see the Surgos. So let's say I see the normal CSC, but the absent or hypoplastic are not
There was
yet.
a point. Yeah, that was a point I made. You have to repeat the examinations if you want to get the whole phenotype in. You have to do a first scan around 24 weeks with the anatomy scan. Then you have to repeat around 29 weeks for the rest of the symptoms.
So the message and one more thing, there are two papers where you should look for the ARSA. The ARSA is quite common in CHG7. So it is, let's say, aortic arc anomalies. So it's not only ARSA, but in one of the first papers, it was written, so it could be anything else. So, but something you say mild, nothing, and then you end up. So this is why what I would recommend for the audience, when you see a cardiac anomaly, you look at the thymus, because we discussed 22-1. But then if you think a moment, the next one could be charged. Look at the eyes, symmetry of the eyes, symmetry of the body, symmetries of the kidneys, the posterior aspect of the eye for coloboma. Look at the ears and try to look at inside the brain. So some odd cerebellum like the one Ashok was showing. So small cerebellum or dilated fossa or univentricular ventriculomegaly, not so really. Something you say, it is not normal, but it's not severe enough to say abnormal. So this is my feeling. What is it your approach as well, Julien? Or?
Yeah, of course. We should try to get the semicircular canals. These are very specific and they're achievable if you're not too late in gestational age. And yeah, the ears, the coloboma, these signs are good pickup for Char syndrome. And Char syndrome is a very severe syndrome. It's not just any syndrome. Those babies are very, very handicapped afterwards.
Okay, other questions, other comments? Michael? So what I liked in one of the talks of Benoit, when he was saying, I will ask a geneticist to tell me what to look for, and when you are putting these together. So I'm really looking forward, especially what Ashok was saying. He looks to Sonio, what are the other features. So I think you will be challenged later on, Julien, to show us how to work with specifically for prenatal people working software, that this is for me the future. You are scanning and in the background there is someone telling you, oh, you see a cardiac defect, the ear is abnormal, check for this, and think of syndrome 1, 2, 3. So if no one has nothing else to say, we'll close this session and we'll just come back with the human intelligence challenging artificial intelligence. Okay. Thank you very much for this nice afternoon. See you soon.
Thank you.
Thank you.
Thank you.